from בינה Clinic, בית התפתחותי. I thought it was a nice name. In באר יעקב Psychiatric Center in the outpatient clinic. I'm doing only adult psychiatry, and I think that I was actually a bit surprised to see how close we were in you know, how many similarities we have. The contents, first of all, just presenting the model of בינה Clinic, the psychiatric comorbidities in intellectual disability, physical comorbidities in intellectual disability, and psychiatric manifestations of medical problems, some case studies. And well, I didn't know that there'll be so many psychiatrists in the audience. I actually was aiming towards how to prepare for your psychiatrist to make the most out of it. Whatever. The בינה Clinic is in באר יעקב outpatient clinic. Right now I'm doing it myself, so I tried to use myself as a very scarce resource, getting into other functioning teams in the community, getting into Bechstein, getting into the welfare, giving my input when needed, and walking back and to other teams that are in need. The references include welfare municipal units, which means that there's a certain bias in the population that I see that have far more physical ailments, social problems, dysfunctional families, etc. Service suppliers like Bechstein and schools, child and adolescent psychiatric clinics that refer to me once the person is 18 or 21, the terrible 21, and special ed facilities. Just to make sure we're you know in the same level, up to 2/3 of intellectual disability adults have comorbid psychiatric disorders, and this means a very large area of disorders. The prevalent ones are mood disorders, autism, ADHD, schizophrenia, and behavioral problems, conduct disorder, many others too, but these are the prevalent ones. And the more severe the disability, the higher the rate of psychiatric disorders. Common medical manifestations of ID. I have 2 slides about it. First of all, it sounds odd, but sometimes when a patient walks in, I have to deal with the physical maintenance of the patient, and I refer to them just like you as the patient. Basic hygiene, vision, hearing, dental issues, and so on and so forth, and I sometimes find problems that could have been easily solved by a dedicated nurse in the community. Genetically related medical manifestations can include, for instance, in Down syndrome, you have a whole pack of them, like heart problems, ear, eye, thyroid. Again, you need someone which is dedicated, knows Down syndrome to make sure that the person gets the right medical treatment. The same with tuberous sclerosis, Fragile X, etc., etc. You usually cannot use the general practitioner from the community to help the patients. Common medical manifestations, other manifestations, stress-related, peptic ulcer, myocardial infarction. The older they get, sedentary lifestyle, especially metabolic syndrome. Most of them, at least the one I see, gain more weight than the average population. They can have sleep apnea syndrome. They have all kinds of diabetes, for instance. Iatrogenic, this is the part where we help out, including medication side effects. Many a time, the teams come in and say, do something, save the day, give them the medication, put some chemical restraints, and make everything, you know, all the hardship go away, and it usually doesn't work like this. Many times we're not the miracle workers. Antipsychotics, for instance, can cause restlessness, they cause muscle cramps, side effects that cause great discomfort and sometimes declining functioning in my patients. Benzodiazepines to calm them down can cause drowsiness, coordination problems, and functional decline that can from baseline. This is the abstract No. Some cases, just, you know, to taste some kind of... I had a 50-year-old male with intellectual disability, moderate, from a hostel in the ER, actually. The primary complaint was anxiety for 3 months. They tried SSRIs, and once she was so anxious, she didn't want to get out of bed, she didn't want to get out of the room. She felt fatigued all the time. They brought her in. In history taking, she's a picky eater, she doesn't eat meat, she's a vegetarian, and she have heavy menstruations. In the interview, she seemed anxious, she was irritable, fatigued, she refused to get out of bed and work. In physical examination, she wore warm clothes, like some of us, but this is too cold. She was pale, her pulse was 90. And she was brought to me as a psychiatrist to see if there was some kind of a miracle I can do with any other medication for her anxiety. She had anemia. This is something that could be easily solved in the community, you know, and RN should have noticed it and sent to the general practitioner. She needed food supplements. She needed something to stop the heavy menstruations. She didn't need SSRIs. Second patient, a 42-year-old female with severe intellectual disability, came from a hostel. Primary complaint was eating problems for a month. And she had to have the food cut for her. She couldn't chew for some reason. They thought it was due to some kind of stereotypy or some kind of obsession to eating in a certain way. She has the occupational therapist is claiming she needs to have the food cut for her. During the interview, she was slow. She was complaining of back aches. She had an odd gait. In physical examination, she has muscle spasms in lower back and in her jaw. She had dystonia. She had side effects of medications that were given to her 1 month prior due to behavioral disturbances. Looking back, they said, we probably shouldn't have given it to her, tried to you know, solve it in non-medical, non-pharmacological means. But she had an odd gait because she had muscle cramps and she had muscle tonus, elevated muscle tonus in the lower back. She couldn't chew because she had muscle cramps in her jaw. And once we stopped the risperidone and put her on just a little anticholinergic medication, she was fine, she was chewing again. Patient C, 35-year-old male with Down syndrome who complained of cognitive decline, including memory and concentration problems. He had a severe family crisis 3 years earlier. His dad had cancer. He was in a hospice for about 6 months. He died. The mother couldn't handle her son. She tried to put him out in a hostel. He felt deserted. He didn't manage he came back from the hostel 9 months later in a far worse shape. They started him off with SSRIs. When the SSRIs doesn't work, they put him on Zyprexa, olanzapine. With the olanzapine, in 2 years, he gained about 20 kilograms. During the interview, he was sleepy. He hardly answered. If I gave him a pillow, he probably would just fall asleep right there on the table. And when specifically asking the mother, she said he started snoring at night. Actually, the first time she paid attention to the fact that he snores was when they went out to a hotel and they had to sleep together in the same room. That was the first time because he has a room by himself, so he has his own room. Oh, God. Okay, so what he had, patient C, is sleep apnea syndrome, which is an obstruction of the larynx causing declining oxygen delivery to the brain. We have it in ordinary people. In Down syndrome, there's a far higher rate of sleep apnea in children and in adults. In childhood, because of large adenoids, and in adulthood, because of obesity and sedentary lifestyle. So the result of not having enough oxygen delivered to your brain during the night, actually suffocating your brain again and again and again for hundreds of times, is daytime sleepiness, declining concentration and attention, depression, anxiety, and behavioral problems. The treatment is CPAP, is a mask during sleep, and of course the best treatment is getting these 20 kilograms off, which is of course a much harder solution to achieve. Patient D, 27-year-old male with intellectual disability, who was presented to me complaining about irritability. She was easily annoyed in the mass, in the hostel. Anger outbursts, preoccupation with toilet. They thought they had. She was obsessive about going to the toilet. She started wetting herself the 2 weeks prior to coming to my clinic. They tried to give her benzodiazepines like Clonix, Acival, which worsened the wetting. During the interview, she said she had a new boyfriend in the hostel. When specifically asked, she said that she had abdominal pain, especially during urination. She had urinary tract infection. The symptoms of persistent urge to urinate, burning sensation while urinating, frequent urination, pelvic and rectal pain, they were all there. It's easier to obtain urinary sample than blood sample, so it's much easier to actually address to it. Okay? Treatment oral antibiotics, after a week, she was far, far better. Okay? Medical issues to address before attending a psychiatrist. Vision and hearing and personal hygiene, pain and discomfort like teeth, ears, abdomen. Ask. Sometimes you'll be surprised at the question, at the answers. Blood pressure, pulse, blood tests like blood count, liver and kidney function, TSH, B12. This is the basic psychiatric blood tests that we do before we attempt starting medications like SSRIs, like antipsychotics, and so on, and complete medical history, including medications and family history, preferably general practitioner visit. I'm sometimes terribly surprised at the patients that come to me. They've waited for like 2 months for this, and they don't bring, you know, any paperwork regarding their medical history and current medications. Questions? No? Self-evident.